and welcome back to DentoTatva. This is our short lecture series, and today in this series our second lecture will be on the topic Endodontic Reinfection. So what you see on the screen is an infographic that I have prepared for this particular topic under these following headings: Introduction, How and Why, the microflora that is responsible, Diagnosis and Retreatment. So beginning with the topic, imagine in a clinical scenario if a patient has reported to you in the clinic with the chief complaint that he previously got his root canal done, and maybe you did it, he was your patient, and could be he got it done from somewhere outside in relation to 1 month say, and he is still, the symptoms for him are still persisting. He still is not 100% satisfied. He is not relieved of the pain that he had before he started with the treatment, and the endo treatment that he got done, the duration has been well over a month or so, but he's still not satisfied. So what should be your thought process? What is the first thing that should strike? The first thing that you need to do is take case history. Then you need to do the diagnosis part. For that, first of all, you need to see the clinical signs, inspect the region. So you need to localize the problem area, and then you need to do the radiographic diagnosis for that. After seeing the radiograph, like supposedly this is the example that I have put up. In this radiograph, you can clearly see the patient had got the root canal done in relation to 1-1 and 1-2. The RCT in both the teeth are below optimum, and this part, if you can see, there is an extruding separated instrument that has gone beyond the canal and it is there hanging, and even the obturation, it is under obturated, it is underfilled. The 3D obturation, as we say, has not been attempted properly. Now this was a female patient that had reported, and this was a referred case to the clinic. So on inspection, it was found that the sinus was there, patient had tenderness in that particular region, vestibular tenderness. Clear that the endo treatment will never have a success rate of 100%. There are always chances that your endo treatment could fail. Under what circumstances can my endo treatment fail? या आपके पास अगर कोई referred case भी आ रहा है, under what circumstances the case might have failed? You need to rule out those reasons. So one of the main reason is persistence of bacteria. Could be intracanal and extracanal. There was inadequate cleaning and shaping of the canals. The irrigation was not done properly. The disinfection was not done properly. So the bacteria persisted and they caused reinfection. There was overextension of the obturated material. Like in that previous X-ray I had shown, there was separated instrument. Apart from that, instrument could be gutta percha, GP cone also, which could have been extruding. So overextension of it. The coronal or the apical seal that were formed were improper, so it could lead to leakage over a period of time, and it could be recontaminated. If there are untreated canals, maybe the previous clinician or maybe you missed out on a canal, there was MB2, there was middle mesial, could be a third canal in upper premolars, could be second canal in your lower premolars or lower anteriors. So all these cases, these anomalous cases, could give rise to a failed endo treatment at some point of time. Procedural error like perforation could be a ledge which you could not negotiate, and the canal patency was not achieved after that. It remained unclean. Primary endo infections are caused by completely different microorganisms, and this is actually a case of secondary endo infections, and the secondary colonizers, some of them are highly persistent to your endodontic treatment. The intracanal medicaments that you are using, the intracanal irrigation that was done previously, those bacteria persisted throughout that treatment, or they reoccurred in those cleaned canals. So the microflora for this are as following. This has been collected from various articles. The percentage varies. The most number and the highly prevalent bacteria are your E. faecalis and Propionibacterium. Other examples are Fusobacterium, Cornybacterium, Treponema family, Candida albicans, most common fungi that is there, and the number will vary depending on the presence of periapical lesions. Now, how do you diagnose? A patient has come to me, so my work should be to see for any kind of clinical signs, the symptoms that the patient is giving. Then I go on with my radiographic evaluation. In some cases, wherein I cannot see the problem on my routine radiograph, that is my IUPA or my radio visiography, that is my digital X-ray, I can even tell the patient to get CBCT done. In cases where my periapical lesion is of considerable size, and I see that the previous clinician has done a fantastic job with the root canal treatment, but still there is persistence of the periapical pathology. In those cases, I can head on with my CBCT investigations to rule out any missed canals, any microfracture there that are not visible to the naked eye. The fracture is not actually in the coronal section, the exposed tooth part. It is in the radicular section and in an unexposed part of the tooth which cannot be seen. So CBCT should be your next choice of investigation. Retreatment can be either non-surgical intervention or surgical. Non-surgical should be your first priority. That is, first you should consider removing the old obturated material, inspect, put intracanal medicaments for at least 2-3 appointments. That should be done. Periapical lesion or the signs and symptoms, they don't subside even after you have attempted the non-surgical treatment and you have given intracanal medicament at least 3 times. You see no change, the patient is still is under a lot of pain, then you should head on with your surgical treatment. So under surgical, this is another example. The first one that I had shown, in this case, you can appreciate that there was an extruded instrument, then this was removed using the file, and in this you can appreciate the clean and clear X-ray of the canal. So this was the non-surgical approach, wherein we decided that it was possible to retrieve the separated instrument and head on with our routine endo treatment, usually do. But in this scenario where the instrument was well outside the canal and there was a chance of us trying to retrieve the instrument, and we could have pushed it farther ahead. Surgical intervention. So when surgically it was intervened, you can see once the flap was raised, you can appreciate in this region the separated file is extruding out. So with the help of surgical intervention, this was removed, the entire piece with the granulomatous tissue, because there is a lesion, non-healing lesion, and go ahead with your routine endodontic treatment. Now there are certain cases wherein there is a periapical pathology and you will need to enucleate. There is a cystic lesion and you need to enucleate that cyst, going forward with the retrograde restoration using MTA or biodentine, and then do the obturation part, close the flap and put the patient on 3, 6, 9 and 12 months follow-up. So this is all about endodontic reinfection. I hope this lecture was helpful in some way. If there are any questions, please don't hesitate to leave them in the comments down below. Thank you for listening. Bye.